Hello, my name is Alora Fryer. I'm a fourth-year medical student at the Florida State University College of Medicine in association with Sarasota Memorial Hospital, and today I will be presenting the unusual suspects, a case of endocarditis with rare polymicrobial bacteremia. So our focus today will be Acinetobacter, and this species is a strictly aerobic, gram-negative, catalase positive, oxidase negative, non-spore forming, non-motile pleomorphic oxybacilli, and is ubiquitous in soil and water. It can commonly cause ventilator-associated pneumonia, skin and soft tissue infections, wound infections, urinary tract infections, peritonitis, secondary meningitis, and bacteremia. Acinetobacter accounts for 1 to 2% of all bacteremia, with Acinetobacter radioresistance accounting for less than 10% of those infections. Acinetobacter radioresistance demonstrates resistance to radiation, where its name came from, as well as desiccation, hydrogen peroxide, and ultraviolet irradiation. The chromosomes may commonly contain class D beta-lactamases, which can hydrolyze the entire beta-lactam antibiotic spectrum. An expression of these beta-lactamases on plasmids may confer further resistance. In 2017, the CDC reported that carbapenem-resistant Acinetobacter caused an estimated 8,500 infections in hospitalized patients and 700 estimated deaths in the US. So while this is downtrending, as you can see in the figure, it is still quite a large number. There were a few co-infections in this particular case, including Enterococcus classiflavus, Enterococcus gallinarum, and Leclercia adicarboxylata. So just a little background. Enterococcus classiflavus is a rare gram-positive cocci. It is vancomycin resistant and primarily found in the GI tract of poultry and domestic fowls. Similarly, Enterococcus gallinarum is a rare gram-positive cocci found in the GI tract of poultry and domestic fowls, though it expresses a low-level resistance to vancomycin. Lastly, Leclercia adicarboxylata is a rare gram-negative bacillus and is often acquired via wound infections and/or contact with other aquatic environments. Our case today is concerning a 63-year-old gentleman who was brought to the hospital due to encephalopathy. He has a medical history of cirrhosis, alcohol use disorder, hypertension, COPD, and an unspecified seizure disorder. He was outside for about 20 hours at a local homeless shelter. At that time, they called EMS, and he was brought in for decreased responsiveness. His vitals on arrival were a temperature of 100.9, heart rate of 135, blood pressure 134/66, and an O2 saturation of 89% on room air. On physical exam, he is chronically ill appearing. He was somnolent, though arousable to voice. He is only oriented to himself. He had very poor dentition and coarse breath sounds with rales in the bilateral bases. His abdomen was mildly distended, though non-tender, and he had scattered excoriations across his body. On labs, he had a hemoglobin of 11.8 with MCV of 94.2, a white blood cell count of 5.3, platelets 77, ET 14 seconds, INR 1.35, an albumin of 3, calcium 7.8, that was correct 8.6, an AST of 193, and an ALT of 72, with lactic acid of 3.9. His chest x-ray revealed a moderate perihilar and lower lobe peribronchial thickening with ground glass opacities, and he was diagnosed with severe sepsis with fever, tachycardia, dyspnea, hypoxia, and a suspected source of pneumonia. He was started on empiric vancomycin and cefepime. Our blood cultures grew Acinetobacter radioresistance, Enterococcus cassiflavus, Enterococcus gallinarum, and Leclercia adicarboxylata, which were fortunately all pan-sensitive. We did a transesophageal echocardiogram, and this demonstrated a 10 by 8 millimeter aortic valve vegetation, revealing endocarditis. So at present of this recording, he's still in the hospital, but we are anticipating 42 days of treatment, both gram-positive and gram-negative coverage, secondary to the endocarditis. We did transition his vancomycin to daptomycin, and we continued his cefepime. So just a few discussion points. Acinetobacter radioresistance contains ALA OX23-like genes that confer carbapenem resistance in other Acinetobacter species through transposition and plasmid conjugation. Acinetobacter in general may be misinterpreted as gram-positive due to retention of crystal violet and decolorization resistance. Monotherapy approaches to Acinetobacter include polymyxins, tigecycline, and minocycline. And combination therapy, when this resistance is present, include any two of the three following. So polymyxins, rifampin, tigecycline, sulbactam, aminoglycosides, or you can risk it with a broad spectrum beta-lactam. So a few concluding points. Acinetobacter radioresistance is a rare cause of bacteremia that has never been reported with co-infection of Enterococcus cassiflavus or Leclercia adicarboxylata. And we must continually concern ourselves with increasing antibiotic resistance, particularly in our broad